This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. We apologize for Dan's audio being a little bit funky until about the 7-minute mark. It clears up then, so just hang in there and it'll smooth out real soon. Welcome to another episode of It's Not In Your Head. I'm Justine Feidelson here with Dr. Dan Bates. Hey, Dan, how are you doing?
I'm good. How are you?
Thank you. Thank you. A little toasty in my office, but I'm going to hang in there. Keep the AC off so the viewers can hear us. It's always positive.
Yeah, it wasn't that good. It was a little bit noisy.
A little of, that's frowned upon apparently in podcast recording. So anyway, today we're going to get into a very important and impactful topic, whether you are a patient, whether you're a caregiver, whether you're like Dan in the doctor role, and in some good examples we'll get into when you flip and are in some other roles within that context. And we're basically going to dive into having difficult conversations, typically around medical decision-making from the both caretaker and patient perspective. And we've gotten a lot of different questions around this topic over time. It comes up all the time in my work with folks and obviously in Dan's as well, whether you're prepping for a surgery or, going through treatments, interventions, that type of thing. So you've had a recent experience with a family member, which is very appropriate for this episode. And I have also gone through some different scenarios, and I'm facing one upcoming as well around explanting my spinal cord stimulator that we'll talk about too. So it involves a lot, right? From a caretaker perspective, there is both grief involved. There's sometimes frustration. There's having to put yourself in the patient's shoe and sort of, why are they maybe struggling in ways that they are? And then given that, how can you help them, right? When we do face overwhelm and we do face these type of difficult decisions that require difficult conversations, so that the things that you have to decide down the line are easier and as least stressful as possible. And as a patient too, right? Letting people help you can be hard. And sometimes communicating what you want or what you hope for in different situations can be challenging, as well as, not just having like hope as a strategy where you hope things are going to work out so you don't plan for the worst. But it is important to plan for the worst and to have different strategies and structures in place so that everybody is on board and everybody is on the same page.
Yeah. I think that last piece is really important. I think I'm sort of making sure everybody's on the same page when you're talking about the care of others, because in this setting, our discussion is about how do you help your family member that is in chronic pain, and to do that, you've got to have everybody on the same page. So that can be hard.
Yeah, especially when patients have brain fog or difficulties sometimes, communicating themselves what happened in appointments or relaying to other family members. It's kind of the classic, nobody told me that, or I don't remember that.
So we had a question about how do I help my, XYZ, my mum, my dad, my child, when they've got brain fog? Because I find it very hard to explain what's going on. So, all right, like give your take. I'll give you my angle of how I manage that as a doctor, and what's your take on from the patient side?
The patient side, for me, it's to lean into the TISM and have really good notes, be really organized, right? So I remember from the TBI days, I would sometimes, obviously if appropriate, even record some conversations with doctors because I literally wouldn't remember appointments. And I was also trying to maintain some sense of autonomy, right? With not having to have maybe my parents come to stuff and that type of thing. And if you're doing that and you don't have a support person, you better have really rigorous notes. And ideally, to be honest, probably have a support person in the room so that you're not the only one who is filtering that and then communicating that. So use things like the patient portal, use things that, innately have record keeping within them. And that will also alleviate the anxiety of what if I forget something? Did I retain everything? Do I know what my plan of care is, and feeling confident in that as the days go on after the appointment? Definitely important.
I think that from the doctor side, there's so many things. You mentioned it before, actually. You said, no one told me. Okay, so I heard that so many times. And that's not necessarily just a brain fog thing. That is just the way doctors speak, the language we use, etc., etc. When we say things, we'll probably say them, but a lot of the times it's in a different language. It's in medical speak.
You said it, but the patient didn't hear it.
Yeah, well, they didn't understand it. For us, Okay, so that's the I don't remember. So how we deal with that, or how I try and deal with that, is number one, we do a patient letter so that we take at least for our initial consults, we convert that into a patient letter that hopefully matches the patient's level of language.
Right.
And matches in some ways their communication style, and so it explains to them what's sort of taking place.
Right.
The other thing that I'm doing at the moment as well, because now we have, I don't know, increasing numbers of episodes of podcasts, I can now go, hey, listen to this podcast.
Right.
It's pretty much just what I said, but you can listen to Justine and I talk about it. I think that's become a increasingly very useful tool for people to be able to listen to. And on top of that, whenever we do like a patient letter, it's got links to fact sheets, etc. So
right, it's got education embedded, basically.
Yeah. So I try and embed the education into the letter, because everyone's going to forget like that. Like everyone forgets, brain fog or not.
Yeah, it's not even always a brain fog thing. And if I put my clinician hat on for a second, it's the same reason why I give my patients recordings of our appointments and a summary, like a written summary, similarly as a letter of what we did. Because the same thing happens to me. I go into PT and sometimes I walk out being like, what did I do? What exactly was I, going to follow up with doing on my own at home? So whether I'm taking the notes or I know where to go for a summary, it's really helpful because it can just be in one ear and out the other inadvertently. And then that creates miscommunication.
Okay, so that's a really interesting point. So you raised the point about recording like twice now. And I think, okay, so the data is that 30% of people record the conversation with the doctor without telling the doctor.
Really? So, I would not have guessed that. Wow. I thought it was like a weird outlier. That's really interesting.
Yeah.
Wow. So, all right.
I think that what's happening there now is that most of us, or a lot of us, are shifting to using AI assistance. So we're now recording 100%.
Anyway.
Right. And so I've I previously, if someone said, "Could I record this?" I would say, "No."
Right, because there's kind of a consent, issue and a trust. Yeah.
There's a trust issue there, but I've moved to, I ask everybody, are you happy if I have the computer help with some notes? 99.999% go, yeah, whatever floats your boat, doc, and away we go. And what's interesting, I had a patient recently who said, "Oh, Dan, you said this, blah, blah, blah." And I went, "Did I?" She goes, "Go to the transcript."
That's your own medicine on you. Check the transcript.
Yeah, and she was right. So I'd missed something. So the other thing that I do, from the doctor side of thing with helping manage brain fog, is I have a very closed history. So instead of asking open questions in that setting, when the patient is then trying to remember what took place X weeks ago and they have no idea, I ask a very closed history and guide them through the history rather than ask me to tell them, so what's been happening for you, which is kind of the way you want things to go in a normal situation. In that setting where the patient can't remember, can't think, can't concentrate.
Yeah, don't make it harder.
It's not going to work. So you have to do a closed history. So, but that's okay. It makes things relatively easy.
Yeah, gives you shorter, simpler answers, ideally.
It does give you shorter, simpler answers. One of the things there I would give a tip to is that if you pick up somebody that is a storyteller, so that they come in and they'll start saying, you'll say, "So, what triggered off your pain?" And they'll start telling you
way back
when
it all started.
And it starts to build up, and all you just want to get to is I had a car accident and I got hit from behind. That's really what I want to get to. You can pick very early that they're a storyteller. I stop them pretty early and just say, "Hey, I'm going to put in an apology now, because I'm going to cut you off because you're going to give me the information I need, and then we're going to need to move on. And please don't be offended, but I am going to cut you off through this." And I go, and it's interesting, actually. A lot of people, a number of people will go, "Oh, yeah, I know, I'm a storyteller. It's okay." And so it gets the uncomfortable bit out of the way, which is useful.
Because then the patient also feels like you are trying to help them navigate the appointment in a way that allows you to help them, instead of you're being a dick, cutting them off. It's like, "Hey, let me help you get what I need. And then there isn't that, I wasn't seen, I wasn't heard. Because a big part of, this overall concept is making patients feel seen and understood and safe and like you are supportive and on the same page with what you guys are deciding on. So that does help from a
And I think
relationship
that
building perspective.
the complaint that comes from the storyteller is I wasn't listened to.
Right.
Every time.
Yeah, can't win them all. Within this, but also kind of the outside of it, we can kind of touch on, this is a bit of a part of that broader conversation of how do you start to navigate, difficult conversations rather than just dealing with the barriers to them, such as brain fog. And it's kind of that risk strategy discussion, right? Or the likelihood of what occurring, the severity of consequences, right? Weighing up kind of the benefit, the extent of the benefit. And Dan, what structure
I
do
had
you
this
kind of...
conversation yesterday.
Oh, all right. Beat me to it. I was going to say, yeah, what structure do you kind of use to think about
I did this
upside,
yesterday.
downside, middle road? All right. Give it to us.
So I'll put into the context, we'll talk a little bit more about this, but my mum's been in hospital recently. And well, the good news is she's on the other side. And I saw her yesterday, and as part of her, landing in hospital, she had a fall. And I'd already put forward hey, we need to get some railings. You're a bit wobbly on your feet,
right?
Blah, blah, blah. Yeah. Maybe we need to think about a ramp, blah, blah, blah.
Yeah, maybe.
And I was, accordingly dismissed. And
that's what we do. That's what we do at the
start.
I don't need that. I don't need that.
And then she falls and, they think she's got a broken neck for however many days. Anyway, so I ended up having this conversation yesterday. And so the big issue with, and I was still getting resistance to, hey, let's put up some rails. I'm like, okay.
I relate to your mom.
Basically what I did is I just wanted to weigh it up. Say, okay, there's two crappy choices here. Okay.
Right.
If you put up railings around the house, what it does is it makes you feel old. Okay.
Right.
And that's totally. Where you're at now, your perception is going to make you feel old. But on the other side, there's risk that you fall.
Right.
And the way that you need to look at that is I break up risk into three components. Firstly, what's the likelihood it's going to take place? Low, medium, or high. Okay.
Right.
Number one. And then number two, what's the consequences of the event taking place?
Right. The risk occurring.
Mild, moderate, or severe. Okay. Yeah. So put into a context for a fall at home in someone who is older. So your risk there, for mum, it's breaking her neck, but also it's breaking a hip. So what
Anything
happens?
Else?
What's the risk if you break a hip? It's a 20% death rate. Okay, so that's the data. Right. There's a 20% risk of death if you break your hip. So that then becomes down. So that's the risk. Broken hip, death, 20% chance. I'm going to go with that's a severe outcome.
Versus feeling old.
No. But then the next question is then the step down is then what's the likelihood of that? All right. So I was having a polite conversation. So I said that it was moderate. Okay. But the fact of the matter is that the likelihood mum's going to have another fall is high.
Medium to high.
Yes. I said I did point out that if she was in the hospital, they'd label her with
the high risk,
high falls risk. Yeah.
Right.
So I just put it into moderate because I was doing the diplomatic thing.
Yeah.
And then we balance that against what do you feel? The downside is here, you're going to feel, at this point in time, you feel like that it's going to make you feel old.
Yeah.
And so it was that structure that I took to walk through that whole process.
Yeah.
And, and if you want to, I don't know if she will have done this yet. I'm being naughty, but anyway. So and if you want, you can flank your mum and talk to her sister, who's also put up railings around her house. And she's gone from it making her feel old to her making her feel safe.
Right. Or
So
but you got to get past the mental piece.
So
honestly,
I'm going to flank her with her sister, telling her it's going to make her feel safe. Don't worry about. I felt old, but now I feel safe. While I go on the other side. So anyway, But nonetheless, they're that's the way I've sort of managed that thing. But the structure is without like using your auntie to flake your mum,
Without pulling in
without
family.
like doing that stuff. You
Behind the
should
scenes,
just,
finagling.
like risk, low, medium, high, severity,
Well,
mild, moderate, severe,
and
and away, have the conversation.
right. And to be honest, it's not that different as when me as a younger person using a cane or using a wheelchair at the airport, right? It's the type of thing where it's like, or I went to the zoo yesterday with friends and I took my wheelchair because it's the zoo. Like it's a lot of territory, right? Could I maybe meander about? Yeah, of course. But you have to weigh that, oh, I don't love this. This doesn't make me feel good. I don't really like it. Obviously, too. I'm going to have a way better time. I'm going to be able to do more. And, you know, I almost feel freer in that thing at times. And so I don't know if I go all the way to empowered, but these things help you do more, and doing more makes you feel good. So does that outweigh that momentary that you kind of got to get past to being like, oh, this was actually worth it and not the wrong decision.
Yeah.
So whether it's railings or assistive devices at whatever age, yeah,
So I
weigh
don't
it
know if
up.
mum's ever going to listen to this, but hey, mum, put up the bloody rails. Anyway,
This is a secret episode.
yes, I'm sure she doesn't listen. Anyway,
None of our families listen to
no, why would you do that? Okay,
no.
so look, we had another question, which was about how do you have like conversations about what might go wrong?
Yeah.
And but I think maybe what we'll do is I'll go on my side first because
Okay.
because there's a broader context and we're talking within the
Yeah.
mum context at the moment. Okay, so mum's just had an operation and she, as part of that operation, one of the risks of it was stroke. Okay, and so what I did is I sat her down and said, "Hey, what if this goes pear shaped? What do you want?" And so is it like, and this is where we really come back to, we want to have difficult conversations to make difficult decisions easier. That doesn't make them
Literally.
easy, that just
Right.
makes them easier. And that was the key to this discussion. And so,
Yeah. That's kind of the takeaway from this episode in a way is
yeah,
how do you, yeah, bridge that?
how do you bridge that? And so there's, and then within that process is then the next step is what do you do once you have that information? So to
Right.
start with, what I did is I sat down and said, okay, these are the things that might take place. Okay. The risks of this, you might have a stroke, and more likely that she was going to get an infection, that when she gets an infection, which has happened previously, she gets very unwell. Last time she ended up in intensive care and,
Yeah. The
blah,
slippery
blah, blah.
slope
It's
begins.
yeah.
Yeah.
And I'm
Yeah.
like, okay, what do you want? Like,
If
if
that
this
happens.
goes pear shaped, what do you want? And I think what took place in that conversation, and in that setting, the questions about what do you want, what you're asking is, do you want to be resuscitated if your heart stops? That's pretty
Right.
much there. And prior to that, do you want to go to intensive care, et cetera, et cetera? So there's things along those lines.
Or like how dependent, Dan, would you be on other people
Yeah,
potentially?
yeah,
And
yeah.
would you want to then continue?
Yeah, yeah. And so
That's,
that,
yeah.
and like you nailed it. That was where she came to. She was like,
Right.
if it goes pear shaped and I'm going to be dependent on others into the future, I
Right.
do not want to have, I don't want to not want to be resuscitated. If my heart's off. And I think that's important, understanding the consequences of resuscitation. So
Right.
CPR is not a benign therapy.
It's
Okay.
not
So
like in the movies?
it's not in them like in the movies. So like
Dang.
if like CPR, you're like, to put into a context, there's a less than 5% chance that you survive CPR if you're in hospital. Because if you're sick and you're in hospital and your heart stopped, that's because like you died and there's a whole stack of other stuff going
You're
on.
already unwell and fragile and
Yeah.
not some top athlete who had a freak heart
Yeah, yeah,
episode.
yeah.
Yeah, yeah, yeah.
And the consequence of CPR is that you get a whole stack of busted ribs, like you break lots of
Yeah.
ribs. And, then there's the consequences of the pain and the pneumonia and the blah, blah, blah that all comes after that. So it's not a benign therapy. And so when you put it into that context, and that's what I did, I said, okay,
Right.
this is, if you are dependent and your heart stops, we do CPR. The consequences of CPR is there's a 5% likelihood that you live. If you do live, you're going to have a bunch of fractured ribs, etc. What would you like us to do? Now, there are some people that are like, jump on my chest, get after it. Okay, no problems. And let's be honest, if we're talking kids, that's what we're doing.
Right.
Yeah. You're talking to someone who's young. That's how we manage things. We throw everything at them.
You're weighing up lifespan and quality of life.
Yeah. If you're older, that's not necessarily the case. But having that conversation is really important. And then having that conversation with family members. So what I did is I brought her partner into that conversation, so he was able to listen to what did mum want. Okay.
Right. So that everybody is on the same page.
Yeah.
Basically. And
so the interesting thing then came, so that mum did get sick, as like no spoilers.
What's predictable.
There. And to be honest, I actually got to the point where I was like, I think I need to talk about it. Do not resuscitate.
Right. Yeah, we've gone past CPR. Yeah.
Can't speak, can't walk. I'm like, oh my God, what the hell is going on here? And so what I was able to do at that point in time is have the conversation with their partner and go, okay, this is where we're at. Okay. We're at a point in time where if mum gets further sick, what are we going to do? And I just drew him in and said, what was your recollection of that conversation? So it got us onto the same page. And like after backing and forthing a bit, we got to the same position where it's, hey, if I'm going to be dependent on somebody else and my heart stops, I don't want to have CPR. So, okay, that's fine. So we're to there. Interestingly, he didn't want to make that decision at that time, and have that agreement. And it was around, well, let's just see what happens.
Right.
Okay.
That's like, oh, but hope is not a strategy.
Yeah, hope's not a strategy. So to see what happens, you can actually do that. You can actually go, let's see what happens, but you have to have a decision-making structure within that. So the decision-making structure is this. The only 3 things take place. People get better, get worse, or they stay the same. Nothing else actually takes place. If they get better, well, then your job's done. And you know what? Mum got better. The day after, I'm thinking she's done. Yeah. She's like sitting up and talking.
Psych.
I'm like,
yep, gotcha.
Okay, anyway, good. High fives are around.
We'll take it.
Good.
Yeah.
We'll take that. The question then is, you can then create a structure where you go, okay, mum, dad, whoever gets better, okay, we're all good. We don't have to have that discussion. We don't have to make that decision. We're all good. Right. If they get worse and they are then dependent on somebody, we know what the decision is. The decision is predetermined. You apply their wishes to that environment. And then the third piece is, and then if they stay the same, I think that, you then, engage with some other people. How dependent are they going to be? What if this gets suddenly worse? And then make a decision from there. And so that's where that's how you then make those decisions, maybe leaning on some expert advice if you're in this situation where they're pretty bad, but not
this awkward gray area.
Yeah, that gray area. Yeah. But I think that's reasonable, and I think it does make the decision-making process easier because you have a structure. It makes it easier because you've got the whole family on board because you've created this environment where you've discussed it prior with the person.
It's like a unified front.
Yeah. Before they can't think. And that's that point when they can't think, that they can't really tell you what's going on. So that's been my, before I hop off this one, what I'm going to say is that in the situation where you do have, older parents or someone, getting medical power of attorney, I think is very important. So mum sorted that out with me years ago. She was like, you're the decision.
You got this. Yeah.
And I think that just also makes things a lot easier because it allows them to make a decision about, hey, I trust you to do this. And
it's also a way of simplifying, if streamlined it.
Yeah. So that's another thing. What from your perspective? So you've lived it.
Yeah. Well, the other thing that comes to mind for me beyond even the, prepare for the different outcomes is when do you maybe do a procedure, or when do you maybe stop a therapy? So, the upsides, downsides, and the risk rewards to, for example, even for me with the spinal cord stimulator, have changed from when I originally got it implanted to where I'm at now. And these type of big decisions, there's a lot of thought that goes into it. There's a lot of, kind of like we touched on, what are the risks if I take it out? Oh, my leg gets worse, I get in a real bad spot, I flare, and I can't just turn the thing back on. What's the upside if I take it out? Okay, my leg's in a pretty stable spot, I can always go to other therapies if and when needed, and it would improve the compensation patterns in my back and my ability to deal with some of the underlying issues that are not battery related, but the battery makes it harder to address successfully. So that's the type of upside downside, weighing that I'm doing as a patient when I'm thinking about, do I want to do this or do I not want to do this? Outside of, once I do it, do I get better? Do I get worse? Do I stay the same? Another good example is, in my past, over the brain injury saga, I had done electroconvulsive therapy, which is not the funnest thing in the world to talk about, but it is a good example of an intense treatment with intense side effects. And when I was going through that process, I was not, obviously, at my best mentally, cognitively. I wasn't really able to make a whole bunch of medical decisions for myself. But what would have been really good to think about prior, and I'm sure there's other therapies that are similar to this, where you think about what's the point at which you maybe abort or stop the therapy if side effects become too great. And what does that look like? Or like, where is that line? And so for me, it gotten to the point where when I got in the shower after many, many sessions of it, everybody gets in the shower and like you put on soap and then you put the shampoo on, obviously before the conditioner. And I remember getting in there and being like, I don't know anymore. Like, I have no clue from a memory perspective what should come first, what should come second. And that was pretty alarming. And so for me, that was an obvious whoa. The side effects of this are now way outweighing the upsides. And that's the type of thing where, from a support person, caregiver perspective, are there things that you can see or you can identify where maybe it's not reliant on the patient going, you know what, I don't know if this is the best idea anymore, but somebody else going, you know what, from observing you, I feel like maybe you're tipping into more negatives than positives. And having people, right, that you trust and whose opinion you accept. And similarly, as with Dan's mom, she gives him power to make medical decisions, even if you haven't given others maybe that power. Have people whose input you value and you trust as an ally to get through those periods where you maybe aren't able to advocate for yourself or speak up for yourself the way that you would if you had all your faculties on board. So the other, and you deal with this too, Dan, in surgery, is risk management. Kind of pivoting back to the stimulator, if you have CRPS, what do you do to prepare for the worst case scenario if you have spread, if you have that type of nervous system flare up from a sort of traumatic assault on your body? Do things with the anesthesiologist prior so that you already have those safeguards in place, and it's not once things got out of control that you're going, oh no, I should have gone through these specific protocols, whether it's ketamine or whatever it may be in your line, to minimize that risk. So those are some situations where you're far better off if you can think about it prior, define and outline some of those things, so that then when you're in that situation, it's not then in crisis that you're trying to decide these things, which, although hard, are even harder then.
Yeah, and I think that, I don't know if this is the right way to phrase it, but maybe one of the benefits of chronic pain is that it's chronic. This stuff's going to take place. You have the opportunity to go to look forward and go, hey, these are things that are going to take place. I'm going to get better, worse, or stay the same. And I can then, you can have those thought processes and you can have those preparatory conversations with family, because there's a low, medium, high likelihood that this is going to take place. And so I think that's maybe the
silver lining. But yes,
but nonetheless, like it is. And I think that most
you
of the
can
time
prepare.
we think about these in an acute setting, which makes it all the more difficult to manage.
Harder.
But unfortunately, if you're living with chronic pain, you already got the signal. Something's probably going to, more at least might be pear-shaped.
Something else is going on. Yep.
One of the important things from a family member perspective is being able to communicate with doctors and
Right.
nurses and that sort of stuff. And we've had a couple of people say, how do I better communicate with
Right.
like my partner's doctor,
Right.
my
The care
etc.
team, basically.
Yeah. And interesting, like I through this process with mum, it wasn't 100% smooth sailing, like let's say the least.
No, there were some frustrations,
There
but
was some frustrations. And as I was trying to, navigate communication with her doctor, the
right.
nurses, the et cetera, I was becoming increasingly frustrated, and particularly with her care in the initial part of things, I was
Right.
like pretty angry.
What the heck is going on?
I remember at one point in time, like looking as one of those posters in the hospital, it says, aggression is never tolerated. Da, da, da. And I was like, I think I'm starting to get a bit of the feel about where that comes from. So I
I'm
was,
feeling some aggression.
yeah, I'm feeling
Yeah.
some aggression. So,
And how do you navigate that without impacting your mom's care, right? Or
yeah. And so I
negatively impacting it.
was, yeah. So I had two things going on there. So I was worried about mum, and and she's gone through this whole process where she nearly died, and no one really knows what's right, like what happened.
Right. Right.
We're just on the other side, and it's sort of like, yeah, this took place. We got these symptoms, but we don't really know what caused them,
What set them
and
off?
she
Yeah.
got better. I was like, okay, great. So that creates confusion, and that creates frustration. But also there was communication issues. And so basically what I did is I actually ended up saying to the doctor, I said, hey, I get you're seriously busy. I'm seriously busy. I don't get it all. Like, I don't nail
Totally
it
get it.
perfectly either. I get it. However, I just need to say to you that this is not good enough at this point in
Yeah.
time. Now that I've been able to say that, let's just move on and let's just get it sorted out. And I
Yeah.
think that I was at a point in time where I wanted to just like sit down and go, dude, what the fuck?
Right.
Like, this
Right.
is not good enough, and
Yeah.
have a crack. And that was just going to make him uncomfortable. And then it potentially impacts on mum's care,
Right.
because I lose my ability to influence it because, they understandably cut me out.
Yeah. Not only
And
that, now you influence it negatively,
yeah,
inadvertently,
and
because yeah.
and I've influenced it negatively, and so that like that's very. And I've always been super aware of the effect of negative, like influencing stuff negatively. So one
Yeah.
thing I and it became so apparent when I was a resident in the hospital. What I came to notice is that the patients that had either a medical emergency call or a code blue column, so that's when you're dying, were always the patients that nobody liked, because they were rude, because they were aggressive, because they were
Right.
whatever.
They didn't see that poster that aggression is not
Yeah,
tolerated.
yeah. And
Yeah.
so, but so it was so apparent to me that I actually used it as a trigger to note these patients
Check
down
on them.
and
Yeah.
go check on them,
Yeah.
because I was like, this guy's an asshole.
All right.
He's
He
the
needs
one
help.
that's probably going to die. So I better go check on him, which
Uh,
is like that is dead set the truth. Okay.
right.
Now,
Unfortunate, but reality.
that is unfortunate, but it is the reality. And so I didn't want to be the one that, that created that negative interaction for my mum. So that's like that's no good. So the interesting, I've got a great, and this is a great technique
Yeah.
for
It's a
doing,
tasty technique.
yeah, for going
Yeah.
the
Yeah.
opposite direction. Okay.
Yeah.
So I had a patient who I just popped into. Once again, I was working in the hospital, and I went in to just change his cannula over. Okay. So I went in and I'm putting in the cannula. Next to it is he's got like a pile of boxes of chocolates, and I mean like a pile. It's got like 20
It's like a
stacked,
stash
like
hoard.
that's a stack. It's not a stash. It's a stack. Stash
Stash.
is something that my little one does when she stashes things in the back of
Just
her
a couple
dress.
in her.
Yeah,
Or,
yeah, yeah, yeah.
yeah. Okay.
And I'm like, mate, what's all the chocolates for? And he goes, look. And he was a patient he had leukemia. He was always in and out of hospital.
Right.
And
Chronic long
so
term.
basically said, look, what I do is as soon as someone comes in and gives me anything, maybe They sweep the floor. They give me my medications. They clean the toilet. They deliver me some food. They do it. I just say thanks, grab a chocolate. And he said, and what ends up happening is that when I push the button because I need something, the nurses come and
They
I
come
go,
running.
thanks, grab a chocolate.
It's
And I was like, oh my God, that
genius.
is so genius.
Yeah.
Just using chocolate to be able to like have people feel comfortable to come and look after you.
Well, and they feel appreciated,
And
so
they feel
how do you get people
appreciated.
to do what you want or need? Make them feel appreciated, right? And
Yeah.
it's can be hard in that environment, but if you can be kind and kind of like Dan was talking about, acknowledge the overwhelm, right? The doctor's feeling, that the staff is feeling, without just boiling over into I'm so mad and frustrated, but can you acknowledge, the limitations of the system like we've talked about in other episodes, and try to influence it in a positive way that is in your favor, rather
Yeah.
than being kind of flagged as a, disliked problem patient.
And so now what I do, like as the family member, because, because they're in hospital, what I'll do is I'll go buy a bunch of chocolates and I'll just take them in 5, 6 boxes of chocolates and say, here you go. This is what you do.
Yep.
And I did this for Dad. So unfortunately, Dad died 7, 8 years ago, but he died of cancer. So he was in and out of hospital a lot. And every time he was in, I just grab a bunch of chocolates and go, here you go. And I would walk in to see him, and the chocolates would be sitting on the thing. And I'd watch him go, thanks very much, grab a chocolate. And everyone
That's
loved
cute.
him. It was
Yeah.
so good. And
Yeah.
so, that's something that you can do for a family member because they're the one in hospital and they're not thinking about that stuff.
Right.
But you take the chocolates in and take in like boxes of chocolates and go, dude, this is not for you. This is for everyone that's helping you.
You can have
And
some. You can have a
you can
couple.
have some, yeah.
Couple.
But it does very much shift the care interaction. It's a great trick.
And
And I've done it for, I remember I had another friend that was in hospital who was having conflict with the nurses, and they're on the phone to me and they're like, Dan, blah, 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 blah. I'm like, okay, I've got this covered. So I just went in, got the chocolates, and it shifted the dynamic with them and their experience in hospital got better. So that one is an absolute cracker for improving care in hospital.
yeah, and especially, when I'm the patient, I've always been conscious of being kind of being, it's not disingenuous or fake, but I go in kind of in a good mood and not like just carrying this like stink of chronic pain behind me where people are put off by you, because then it's really hard to kind of get the treatment that you need. But the reality is also that sometimes as a patient you can't put on a good face, and if you can't put on a good face, at least have chocolates where it's really easy to just go to that, and and you don't have to do this like charade of acting happy when you're not, because that's hard, and I'm good at masking. Not everyone is good at masking, but doing small things like that add up, instead of getting to a tipping point too, where I have in treatment gotten so frustrated, right, where you're leaving voice message after voice message and you sent 3 MyChart messages and no one's called you back, and it's like I've done everything the right way, and I'm feeling ignored, and I'm the boiler meter is going higher and higher, and it's not helpful to send like a scathing nastygram to your doctor to like communicate how frustrated you are. So before you get to that point, if you can implement some of these tricks, it decreases the stress on you, it makes the staff like you more, and that's also part of managing that feeling of like a lack of control, because as a patient, that you're trying the best you can to control your care, but there are a lot of elements of the system that you can impact. So nurses like you, it's helpful. You with your mom too, Dan, the nurses and the support staff, how did that kind of bridge the gap when you, for example, couldn't communicate as well with the doctors, and just make you feel a little more comfortable and
Oh, yeah, that time. Yeah.
right, like
So,
these little micro communications that make a big difference.
so at the point in time when I'm trying to reach out to the doctor and I can't, regardless of what like doctor tricks
Yeah,
I
yeah, yeah.
pulled, there was 2 nurses that just they just gave me some additional information. I think one of them recognized me from somewhere, but that's probably irrelevant. They just gave me that little piece of information, which gave me more control. And
Right.
did it really change what was happening? No, but it was a very kind conversation that allowed me to feel under more control at a point
Yeah.
in time when I, was not
Was
in control.
struggling in that department. And
Mm.
another good example of this, if you put kind of your back to your doctor practice hat on, is a way that you've helped patients feel more in control and more like they can reach you and communicate, is actually giving out your phone number,
Yeah,
which
yeah.
is
So
pretty
I've got a
unusual.
patient phone number. So that, and it was interesting. I never gave out my mobile number, and
Well,
I
it's
suppose
like, yeah, nobody,
I
yeah,
reflected
nobody
on this
does.
recently, in that, like, I'm trying to get in contact with this doctor looking after mum, and I
Right.
couldn't, and like the stuff online is, not connected, and when I get to something, the mailbox is full, like
Yeah,
the
yeah.
voicemail box is full, and stuff along those lines. And one of my older colleagues he was like, he just gives out his phone number. I was like, Dave, like, what are you doing? He goes, no one abuses it, Dan. He goes,
Right.
and it's not 1980. You know who's calling you, and you can always block them. I'm like, oh, that's a good point.
Yeah, yeah.
So I shifted at the bottom of all my procedure reports is, mobile to get in contact with me, etc. And I got to tell you, it is the best decision I made with regards to care, because people don't abuse it.
Right.
People call me, like, pretty much after they've tried multiple things. Like, get on the phone to me on Sunday afternoon. No one wants to
Do
do
most
that.
people don't, nobody really wants to be annoying, it's not,
No.
yeah, yeah, yeah. So it actually is very, it's counterintuitive, but
But
once you think about it, it actually makes sense that no, it's
And
not
the
going to get.
interesting thing is that, from my perspective, it's become very apparent there's only two management strategies. Okay. There
Right.
is, okay, I need you to go to the emergency department, and then they can call me from there. Like, that's,
Right.
so I will determine whether I think this needs to be dealt with, like, right now. And so that's number one. If it does need to be dealt with right now, they need to go to the emergency department. That's pretty straightforward. And number
Yeah.
two, okay, what we're going to do is we'll treat it like this, which is generally some sort of pain relief that I give them some guidance of, and I'll talk to you tomorrow.
Right. Just bridge the
Okay.
gap, make them feel
Yeah.
better in the meantime. At least you took some
If
action.
it goes
Yeah.
pear shaped in between, go to the emergency department. Okay.
Right.
And so that, but those two management strategies. So from a doctor perspective, like giving out mobile number, it's kind of like, yeah, whatever, it's good. Like, it like simplifies everything, makes things, like, allows you to sort stuff out there and then. It allows you to cut off the major disaster that's
Right.
brewing, that
Right.
people sit
Right.
on for, like, days,
Yeah.
and it's not actually complicated. So
No. You
that's good.
decrease anxiety and increase the sense of,
Mm, for
not
everybody,
necessarily
including me.
control. Yeah. 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 Puts the doctor in less of a pickle. So
So yeah,
all of these
that's
different,
been a good move. I like that one.
yeah.
Thank Dave for, like,
Thanks,
teaching me that
Dave.
one.
Right. So yeah, so whether you're caregiver, whether you're a doctor, either side of that, ideally as the patient too, we did an episode on, are you overwhelmed, right? How do you deal with overwhelm? And so the quicker you can kind of recognize I'm overwhelmed, or this is what would help me feel less overwhelmed, or this is who, can recognize I'm overwhelmed, or I can tap when I'm overwhelmed, or better manage. How do I communicate when I am and simplify things? Also, from the doctor perspective, there's a lot of good nuggets, because the more intense the situation gets, the harder it is to manage without these type of like ball drops, which if can be avoided, make an already difficult, experience more positive, which
Yeah.
does make a difference.
All right.
Is there
So
anything?
look, to wrap it up, I think the main point I wanted to make today is, if you're the family member, be comfortable to make, or if you're the family member, be comfortable to have difficult conversations so that you make it easier in the future to make difficult decisions. But
Yeah.
that is the key to communication, and to be able to support, all those that you love that are suffering
Yeah.
chronic pain.
Yeah. Be measured, thoughtful, do things in advance, not after the fact. Don't hope it works out. You can hope for the best, but be prepared for the
Yeah,
worst.
yeah.
And then you cover all your bases, because it's easy as a patient to just be like, it'll be fine. It's going to be good. And there's nothing wrong with that attitude and that perspective. That is how you want to go into these types of things. But don't put yourself in a situation where you're not prepared, when you haven't thought this stuff through. And then maybe you have decisions being made that you were not so on board with or super thrilled about. So yeah, expectation management is an ongoing piece of, of chronic pain care for everybody involved. And hopefully this episode gave some good strategies, from chocolates to voicemails, voice messages, cell phone numbers,
Mm.
so that you can navigate it better.
Yeah.
Anything else, Dan?
No, that's all I got.
All right.
Thanks, Charles.
Cool. See you guys next time on It's Not in Your Head. Thank you. This is It's Not in Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers.